Hey everyone, good afternoon. Today we're going to be talking about data-driven approaches to patient outreach and stratification. If there's one thing that we took away from COVID in the world of primary care and population health management, it's that we need to work hard to engage our patients. And we have an opportunity to do this at scale, because what so many of us would love to do is be able to reach out to our patients individually. Talk to each of them one-on-one, live, about their care gaps, about their opportunities, the ways that we as a healthcare community can improve their outcomes. And we also know that that's not something that scales well. So most organizations need a patient engagement strategy that is both tailored to the patient and engages them individually and scales effectively across hundreds of thousands, if not millions of lives. In order to do this, one of the best things that we can do is have effective processes and tools for stratifying our population, for understanding how we can reach out to groups of patients and make it feel individual, because everybody wants to hear from their PCP and feel like the message is for them and not for everyone in the phone book. In doing so, we often think about divvying up the population as low risk, rising risk, and high risk. But what we also know is that none of those cohorts represents a set of patients that truly has the same needs and the same context. So one of the best things we can do is think about how to approach cohorts within those cohorts, creating more tailored and customized groups. We're going to run through a few examples and then talk about some best practices for implementing this type of approach. As we think about the low-risk population, this is what we often think of as the young, the healthy, the invincible. Many patients on commercial insurance, for whom the most important thing from a healthcare standpoint feels like it should be not getting hit by a bus and not breaking a leg. While we know that the most important thing for these patients is getting routine primary care and getting the appropriate preventative care, whether it's kids getting immunizations and having their well visits, or adults getting things like cancer screenings, being monitored regularly for chronic diseases to make sure that they can be caught and addressed and managed early on in the progression. Some of the best opportunities here are around educating patients around the importance of each of those activities. One thing we often see in reaching out for cancer screenings is that patients on the younger end of the age range are often less likely to respond and be activated off the first text because they may not know that colorectal cancer screening is relevant at their age. They think of it as something for someone older. They think of that as something important for their parents. They don't think of it as applying to them. So this is an opportunity where before we send reminders, we want to focus on sending education on why it makes sense for this population specifically to be receiving this type of care. We also know that this is the more tech-savvy population. It's folks that can be a little bit busier if they're on commercial insurance that they have through their jobs. So we know that there's an opportunity here to leverage tech wherever possible. These are the folks that are going to be more comfortable logging on to MyChart late at night or on the weekend to schedule an appointment on a location that's convenient for them. These are the folks that are going to want to leverage primary care through virtual visits. And that's going to make sense for them because they're less likely to need a lot of lab work or anything else that they may need to come in person for. And where just capitalizing on really the equivalent of a quick video call can be a really important pathway for engaging that patient and building the relationship with the PCP. As we think about that rising risk, this is the spot where you've got a truly impactable population, an area where you have patients with early stage chronic diseases that may be starting to pick up. This may be the patient who's been to the ED twice and hasn't gone back to primary care yet. A diabetic with COPD who's had one readmission and may or may not have a second inpatient stay in the next year. This is one of the places where it's so important to start tailoring the communication because you wouldn't necessarily send a terribly effective blast to a population with different context for chronic conditions, past utilization, etc. You don't want to be creepy here, right? You don't want to say, hey, heard about your ED visit last week. Time for us to talk about that. But it is a great opportunity to emphasize the value of primary care and to speak directly to a patient's condition. Presenting information, for example, about evidence-based guidelines around care for diabetes, COPD, hypertension. It's a great spot to reach out early to patients who may need a little bit of extra assistance to get adherent on their medications. When we see a patient who gets the prescription, picks it up twice, then 2 or 3 months later gets their third fill and then stops picking it up altogether, it's a great opportunity to reach out to the patient and ask what's going on. Are they having side effects? Are they having a hard time affording the copays? These may all be situations where there's opportunities for the healthcare system to support them that they may not be aware of because they don't live and breathe some of these things day to day the way that many of us in the healthcare, and in particular the population health space, do. A few suggestions I like to call out here around targeted education, leveraging that PCP relationship. In sending millions of text messages a year, we see markedly higher response rates in messages that are sent from a patient's primary care physician, calling out the practice or the PCP by name, as compared to messages that are coming from health plans. And in many cases, those messages are coming from a partnership between the plan and the organization. So it's not really a difference in who's sending the message. It's a question of who the patient is more open to hearing from. This is also a great spot to start thinking about barriers to care. Looking ahead and saying, we know that this patient needs to see their primary care physician, to see their specialist. What could prevent them from that? It's a great opportunity to segment that population a few layers deeper. At the most basic level by asking, what's the patient's preferred contact language? Am I reaching out in English to a patient who speaks Spanish, who I know needs a translator every time he comes in to see us? We know that when we send messages in the patient's native language, the response rates are as high for patients of minority ethnicities and races as they are for white patients. Meaning we know that we can break through these barriers, but it's a matter of engaging the patient on their terms. It's a huge spot to look at whether a patient may have challenges with transportation, whether there are other barriers that would prevent them, again, from getting the care that they need in order to get their outcomes trending in the right direction. And finally, we think about that high-risk population. And this is where we have the opportunity to do very targeted, very rapid, and really vigilant engagement to make sure that patients don't miss a beat. Because we know that these are the opportunities to make a significant difference in the patient's outcomes and cost and care very quickly. These are the spots where you frankly get a little bit more shameless about following up on the discharges, emphasizing sometimes multiple times after a patient leaves a hospital why that primary care follow-up is important. In some cases, this is as easy as texting a patient that you're going to be calling them to schedule a follow-up visit, and here's why it's important. So when they get the phone call and pick up the phone, they've already been primed for that message. They understand the value of that next visit, even if they're not feeling up to going to the office and dealing with the medical care setting again. This is where you'll often have follow-ups for missed appointments. Follow up with patients around care management programs, maybe messaging or sending them informational materials around the type of support that can be available from a care manager or a care navigator, in addition to putting in a phone call to make sure that the patient feels comfortable to answer any questions that they may have. This is an area where speed can really make a difference, especially if you're talking about programs like transitional care management, but also an area where we know that there's an opportunity to be consistent, to reach out regularly. Sometimes looking for ways to engage family members, making sure that there's a good opportunity for an open dialogue across the patient's care continuum. So as we think about stratification, where I think we land here is that there's a huge opportunity to think of cohorts as more than low risk, high risk, having a condition, not having a condition. There's a lot of room for us to get really deep in identifying just the right patients who can be impacted by a particular piece of outreach. This might be reaching out to patients with an individual gap in care and perhaps digging deeper and saying, hey, we're not just saying that mammograms are important. We're saying that there is a location where you can get a mammogram that has appointments open on this day. It may be a spot where we're reaching out in other targeted ways. Social drivers of health, we talk about a lot because it makes a huge impact as to whether a patient thinks and has the confidence that they can engage in this care effectively. It's a spot where it's critical for patients to hear that the healthcare system is designed for them. It's not for someone else. It's not for someone who speaks a different language or has more money or comes from a different background. It's important for patients to hear that now is a time where they can get engaged with care, where they'll receive the support that they need. There's a number of other tools here, including some of the recent developments around building out impact models, identifying patients who are likely to be impacted by certain types of care. Taking a look at just a few sample use cases that have been in place with our customers. We recently worked with a Medicaid accountable care organization in Massachusetts to build out a behavioral health impact score. This looks at patients with chronic conditions and behavioral health challenges to understand where historically patients who receive behavioral health interventions have had improved outcomes on both the behavioral health fronts as well as their traditional medical outcomes. And one of the reasons that's so exciting to me is that we know that behavioral health is a comorbidity. It adds a ton of complexity to a patient's ability to engage in care. And we know that we can't push it off to the side and say, well, someone else is going to treat that. That's fine. We're just a medical care organization here. We've also worked with organizations to carve out registries specifically around social drivers of health. And we know that data is a huge challenge here for every organization. There are plenty of opportunities to find some data sets to try to carve this out of the Z codes that may or may not have gotten coded appropriately. But a lot of the opportunity here can come from carving through the EHR record to understand where patients had referrals to social services in the past, where something's dropped on the problem list, where it's been captured in free text notes, to start to build out messaging that either works specifically to address a particular factor or incorporating it into other educational messaging, such as education around diabetes that focuses on the challenge of affording really good nutrition that's necessary for managing the disease. Another really common one, again, common for Medicaid, but also commercial, is high-risk maternity registries. This is another spot where using data rapidly to reach out to patients can make a huge difference. Because there's no point in running a report identifying patients that were pregnant a year ago. This is a spot where we want to be capturing data from the EHR. We want to be grabbing those ADTs to recognize if a patient has recently been seen in a hospital, is starting to develop hypertension, in order to identify opportunities to engage that patient early and work with them consistently to make sure that they receive the care that they need. To wrap up here, just a couple of best practices I'll call out. First and foremost, we want to leverage data to stratify patients. Sending broad blasts can be a good starting point. It's what many organizations did during COVID. Getting the communication started, telling patients that virtual care was available or that offices had opened again. But as we move past those 101s and those building blocks of patient outreach, we want to start leveraging data to target messaging that's going to speak with the patient and truly resonate. You can use that to create actionable cohorts. Again, nobody wants to receive a message that feels like marketing. We all want to be spoken to about our own health, about our own challenges, our own concerns in a way that resonates. and makes us feel confident that we can receive the right level of care. And finally, encourage organizations serving any populations to think about barriers to care. Work with care managers, work with social health workers, poll your providers for what they're hearing from patients to understand what the concerns may be, why patients aren't engaging, why patients have stopped picking up a medication or are now only picking it up every other month. These are all opportunities to understand why patients don't adhere to their care plans in order to make real progress in the care that we provide, as well as their outcomes. Would love to open it up, see if folks have questions or other experiences that you'd like to share.
Try and phrase this as best I can, but I'm curious about the intersection between stratification, hard data numbers, and like taking an empathetic approach to communicating with patients and how you advise marrying those two processes, I guess.
I love that question because it really speaks to the fact that no one wants to be messaged in terms of a number. No one wants to be told, so I see you're an HCC of 7 3/4. Let me pull up the 6 and up interview list. I think that this is a spot where it's so important to acknowledge that any mass outreach is only going to take you so far, right? I think that a lot of the opportunity of something like a big blast of text messages, et cetera, is to get patients to the door, to start the conversation. And it's a spot where when we think about how these tools and algorithms are used, it's critical to think about the next step of what actually happens at the point of care. And particularly as AI in healthcare advances and becomes more broadly used, we see all kinds of horror stories, right? I mean, how many, exposés have we seen about the Medicare Advantage plan that used some system or another to say that the length of stay for this patient should have been 8 days. So on the morning of the 9th day, out went the patient with no seeming regard for what their actual needs were. And that's a spot where it's easy to look at that and say, man, AI is never going to take the place of a doctor. And I would never say that it would. But it's also a spot where we need to take some responsibility about how we're using AI and how we're using our data, and acknowledge that that information should be one thing that you know about a patient standing in front of you that should fit in somewhere with everything else that you're seeing, the patient's own lived experience and what you're hearing from them. And I think that that's probably one of the most important things that we can do, is make sure that we're still empowering our providers, our care managers, our navigators, everybody working with a patient, empower them to work with the whole patient, pulling on that data, trying to learn something from it, but never letting it be the end-all be-all or any kind of substitute for a real conversation. Thank you, guys.